So this is a very recent paper, and here are the current recommendations regarding the evaluation of middle-aged and senior individuals. This is the typical marathon runners. When you remember it, it's about the age of 42 to 45 in mean age, and this is a consensus statement, and I will focus on this consensus statement now. And the aim of this consensus statement was to establish a practical method, and this is very important, because if you don't have a practical method, then no one will use it, and so the paper isn't worth to be published. But I think this is a very practical method described within this paper, and so I will present it to you. And another intention is to encourage individuals to participate in regular physical exercise. And this is also very important, because we don't want to make someone frightened of exercise because of the potential risk, which is pretty low, of sudden cardiac death. So, which are the different topics which are important for this evaluation? First of all, it's the individual's cardiac risk profile. Then the current level of physical activity and the intended level where he or she wants to be at the marathon race, perhaps. And yeah, you see the cardiac risk profile. It depends on two big factors. First of all, the known classical risk factors like blood glucose, metabolism, and lipids, and also blood pressure, but also family history and the individual fitness level and the actual fitness level. And how can it be assessed? First of all, and I think the most important assessment is a form of self-assessment with a validated questionnaire, and there are two questionnaires actually, two bigger ones. One is from the AHA, and the other one, I think you heard from it, is from the PARQ. And this one is a little bit, yeah, I don't think it's so nice like the PARQ, because when you look at the PARQ, it's the new PARQ Plus questionnaire. First of all, there are only 7 questions which each athlete has to answer, and if all of these questions can be answered with no, then everything is fine, and the athlete, he's clean for activity, as it is written here. If one question is answered with yes, then he has to go to the next 2 pages, and then it's also getting a little bit extended, and there you see a question regarding all systems of the body, like the musculoskeletal system, here cancer, heart and cardiovascular disease, metabolic disorders, pulmonary system, and also neurology. And then, depending on this, there's another recommendations regarding the contact to a physician. And this contact to a physician to assess here the classical risk factors is facilitated by the score system. I will show it to you, of the European Society of Cardiology. This is the panel, and there you see this is the panel for the low-risk countries, and this is the panel for the high-risk countries, and I will show you here the panel for the low-risk countries, because Spain and also Germany is here within the low-risk region of Europe. And this is divided in accordance to gender and also to smoking state, and then you have a look at the age, and there at the total cholesterol in the blood and also the blood pressure. And if you know these 2 factors, then you can estimate the 10-year risk for a cardiovascular disease. And you see the higher risk if the 10-year risk is above 5%, and it's here within all the red marked areas of this chart. So you can estimate the risk, and if it's high risk, then you have to do further evaluations. Then in this paper also, high risk definition isn't only the ESC score higher than 5, but also a raised blood pressure and also a blood cholesterol. And also a diabetes with a known damage of the kidneys as a sign of an end organ damage, and also a premature cardiovascular disease in a first degree relative, which is younger than 50 years, and also obese athletes are at a higher risk. So when we want to have a look at the current level of habitual physical activity, then I think we can estimate it with the metabolic equivalence, and there I showed you some examples, and the total volume can be calculated with a multiplication of these METs and duration, and then we get the MET hours per week. And so when we look at the intended level of physical activity, this depends very much on the individual exercise tolerance. So I'm going to show you, or I'm going to discuss it with you, how we can evaluate this individual exercise tolerance, and perhaps you have some ideas. And there we see at the intended level of physical activity, low intensity and moderate intensity, it's less than 6 METs, that's really low, and there's high intensity, and this is more than 6 METs. So this is for sure, it's marathon running, it's high intensity. And when you look at the current recommendations of the ESC for the age of over 35 years old, and there you see for sedentary, we don't have a look at this because the marathon runner, normally it isn't a sedentary person, and so we're going to move to the active athletes, and there you see it's a high intensity activity, and then the recommendations, they show a screening by a physician, and this is not only history and physical examination, but also a risk score, which I showed to you, and also a resting ECG. And if there are any abnormal findings, like a high risk score above 5%, or any symptoms or any abnormal findings during the examination, then a maximum exercise testing is recommended. And then at the end there are perhaps even more examinations. So this is the recommendations from the AHA. It's only for competitive athletes, and it's also a little bit different from the age. It's only about 40 years old, and it's a history and a physical examination, and in the age group which is higher, which is about 40 years or 50 years within women, +1 cardiovascular risk factors or symptoms, then there's also a maximum exercise testing recommended. And all athletes above 65 years, regardless of any symptoms or complaints, also a maximum exercise testing is recommended. So what are the limitations of this maximum exercise testing? We know that it's often not conducted until fatigue. So if you stop at about 80% of your maximum capacity, then it's false negative. And we also know that there are additional costs, like I showed it to you in our case, and it was a huge amount of costs after it, and this might be one problem. And also these facts, in asymptomatic athletes, there's a very low sensitivity and also a very, very low specificity. So what are the causes? If you look at the degree of the severity of the coronary stenosis prior to a myocardial infarction, then you see that about nearly 70% it's only a minor stenosis, and you won't find these minor stenosis within maximal exercise testing. You would find only this one with a relevant stenosis with about 14%. So you won't get the big part of this stenosis, and the testing would be false negative.